Thank you for joining Cancer Support Community Atlanta for Frankly Speaking About Precision Medicine, facilitated by Dr. Bordoni with Georgia Cancer Specialists. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to Frankly Speaking About Precision Medicine. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, to see all the free oncology support services offered virtually. We're excited to introduce a new 4-part physician-led educational series titled A Focus on Cancer in the African American Community. Each program will focus on a specific cancer type and how it affects the African American community. For additional information on that program or to register, please visit our website, cscatlanta.org. As I said earlier, everyone will remain muted. Throughout the presentation, we invite you to enter questions into the program chat box, which Dr. Bordoni will address during the Q&A at the end of the program. I want to welcome our presenter, Dr. Bordoni. Dr. Bordoni is a board-certified medical oncologist with Georgia Cancer Specialists. He's the Director of Clinical Research and the leader of the Phase 1 Clinical Trials program at Georgia Cancer Specialists. He's a member of the Northside Hospital Cancer Institute Lung Cancer Research Subcommittee and the chair and founder of the annual Atlanta Precision Oncology Symposium. Dr. Bordoni is the founder and ex-chair of the annual Atlanta Lung Cancer Symposium. His clinical interests include lung cancer, head and neck cancer, and research. So welcome, Dr. Bordoni, and I'll go ahead and pass it off to you.
Thank you, Katie, and thank you everybody for coming on board for this meeting. So you can see actually on your screen what we plan to cover during this workshop. So the slides actually have been reviewed by Dr. Gerald Messerschmidt. That was in June 2020. So the data actually is very up to date. And this program has been fully developed by Cancer Support Community. CSC develops the content independently and then has outside medical and psychosocial experts to review it. CSC has final control over the content of the program. The program was sponsored by Bristol Myers Squibb, Foundation Medicine and Genomic Health, and myself was engaged by Cancer Support Community Atlanta. So I do not have any financial relationship or affiliation to disclose, and I'm not being paid by BMS Foundation or Genomic Health. So what is precision medicine? So one way to define precision medicine is also called personalized medicine, a new way to look at what is the right treatment for each patient. I prefer, however, another definition. The definition is more visual. If you can imagine, actually, until a few decades ago, we stopped looking with a microscope, and we have been doing that for centuries at the level of the cell. So if two cells actually look similar or even identical, we consider those two different tumors the same. So one coming from one patient A and the other one from patient B. Now, actually, with new technology, we can get into the cell, we can get into the nucleus, and we can get into proteins or even more, the DNA in the cell. And then we can see that at that level, protein and mainly the DNA, those two cells are totally different. The molecular makeup of cell A from tumor A is very different than cell B from tumor B. However, in the old times and until recently, a few years ago, we were treating the patient with tumor A and B the same way. Now we know that the tumors are different, so our approach is different. And that is what we call precision or personalized medicine. I'm not talking about precision medicine because it's a broader field and topic. I'm going to talk about precision oncology. So in the field of cancer only. So the old way, one more time, to treat all cancers of one time, for instance, lung cancer, breast cancer, colon cancer, was with the same treatment. Again, we had a patient that by microscopic evaluation, the cells actually fall into the, the characteristics of adenocarcinoma or squamous cell carcinoma. So we have a specific treatment, usually chemotherapy, for all the cells looking the same. Instead, in precision medicine, we doctors try to find our specific subtype of cancer by using biomarker testing or molecular testing, like I commented before. The result of these tests show which treatment will likely work best for you. Now, we know over the years, actually, we know that there is a lot of data in the DNA analysis and the protein analysis that is redundant, or maybe it's not redundant, but we don't know how it works. We don't know what encodes for. And because of that, we cannot use that portion of our DNA code or our protein makeup as a target. So slowly we are learning. And almost every day there is a new publication of new portion of the DNA, the genome that we call, that we can use as a target, and a new target agent that is developed for that specific portion of DNA. But also actually what we are doing is reinventing all pieces of DNA that we call genes, if they have aberrations, alterations, that many times we call mutations. We know now actually some of those mutations may have more than one function, may respond to more than one target therapy. So we understand actually we can use them as more than one target. The way precision medicine or precision oncology has developed is so phenomenal in just a couple of decades that in some clinics, in some cancer centers are not organized anymore by the disease, like breast cancer clinic, colon cancer, lung cancer clinic, but by the molecular makeup of the tumor. It doesn't matter, patients with breast, colon cancer, lung cancer, thyroid cancer may come to the same clinic if they have the same molecular profile, because the treatment will be the same. Again, precision oncology goes beyond the boundaries of the type of cancer. It organizes the patients or group the patients according to the same molecular makeup. So what is unique about you and your cancer on a molecular level? So let me tell you some. This precision oncology, I would say that actually the first that I remember about the application is in 1966. By then, a pharmaceutical company, ICI, that now is called AstraZeneca, was trying to develop a contraceptive. And they developed a medicine that is called tamoxifen. Tamoxifen in 1966 was introduced in the oncology world to treat patients with estrogen receptor or ER positive breast cancers. That is more prevalent actually in elderly breast cancer patients. The prognosis is better, and those patients actually, in addition to surgery, radiation, and chemotherapy back then, started being treatment with tamoxifen. Tamoxifen actually will block the receptor, the estrogen receptor, and it could inhibit or block the growth, metastasis, etc., of the breast cancer cells ER positive. So we're talking 1966. It took actually many decades to recognize actually that was the first target or precision medicine approach in the treatment actually of a cancer, in this case, breast cancer. Now, let's jump to the late 1990s. And that was actually the identification of a fusion that is called a Philadelphia chromosome, that is very typical or characteristic of patients with CML or chronic myeloid leukemia. Then a compound that is called imatinib was developed. And it was developed actually by a lead researcher at Dana-Farber and Harvard. And that person actually was nominated for the Nobel Prize. He so far actually didn't get the Nobel Prize, but has been nominated. So that changed the treatment of this disease, chronic leukemia, and patients now with chronic leukemia, some of them may be cured. Now, that is the other concept that I want to introduce now so we can follow what is unique about patients with cancer and a target that can be treated with target therapy. Unfortunately, tumors in general are smart. Even when we divide the tumors, and we have been doing that for a few decades, between smart tumors and stupid tumors. Stupid tumors are those actually that have one mutation only, because most tumors, they have more than one mutation. So if you target one mutation, they can escape the targeted therapy by using another mutation to continue growing and metastasizing. CML and the treatment of imatinib for many years actually was considered to be a stupid tumor. You target that only mutation, that patient actually tumor goes away and never comes back. Those patients were treated for 7, 10, more than 10 years, and then in 30% or more of those leukemia patients, when you stop the target therapy, the tumor started growing again. So this is the second concept. Precision oncology these days controls the disease, may put the patient in remission, but is not equivalent to cure. Some patients may be cured, but they are 10 or less than 10%. Most of the patients, the disease is controlled, the patient improves from the clinical standpoint, but unfortunately, sooner or later, in many months or in several years, the patient may have to go on a different type of treatment, the typical chemotherapy of the past or another target agent to keep the patient in remission. So how do you obtain or perform these molecular markers? You take a sample. In the old times, meaning old times until 3-4 years ago, the sample was tissue. Also body fluids like pleural effusion, fluid in the abdomen from ovarian cancer, etc. More recently, we can take a blood sample, 10 cc's of blood. We can recover the DNA that is being shed by the tumor in the circulation, and we can analyze those molecular aberrations, those DNA mutations, fusions, etc., that we can use as a target. So when you get actually the test results, for instance, this morning, I got an email actually from a molecular lab, and told me that a patient with a cancer of the ovary had a mutation. The mutation was PI3K. Recently, there is an inhibitor of the PI3K mutation that can be used in patients with this specific mutation. There is a great example of biomarker testing and or molecular testing and precision oncology or precision medicine. So this patient of mine already received the report. The biomarker testing, also called molecular or tumor profiling or somatic testing, was called this morning. We made an appointment for tomorrow, and we are going to be discussing with this patient to go on a simple pill. Now, when we say simple, I want actually to make clear, even when it's a pill, there are side effects from target therapy. So chemotherapy, immunotherapy, etc., they do have adverse events or side effects. The same actually with most of them being pills, which we consider these days target agents or target therapy. So the biomarker testing is used by us to determine the subtype of your cancer. In the patient I just told you, very few patients have the PI3K mutation in ovarian cancer. So my patient, look under the microscope, look like any other ovarian cancer. And most of those patients will go on chemotherapy. Chemotherapy and maybe some target therapy, but not a pill. A target agent given IV. It could be an anti-angiogenic agent, I will explain to you what it is in a minute, or immunotherapy. There is another modern way of targeting tumors. But in my particular case, this is the difference between her ovarian cancer and other cancers of the ovary. We now know that this is specific for that cancer, and we will use target therapy as a personalized approach to her specific cancers. So that is the application as an example. So what biomarkers can tell you? To look for early signs of how well your body responds to a specific treatment. So it's a predictor of response to the treatment. So if you do have the mutation, like the PI3K I told you about, most likely this patient will respond to the PI3K inhibitor that was developed specifically for that mutation. Now, every single 100% of the patients with ovarian cancer with that specific mutation will respond to the specific targeted agent? No, there is nothing like that in medicine. The response 100% doesn't exist at this point. If we see 100% response rate, maybe in few cases and mainly at a certain point in the development of a specific treatment. But later on, as we gain experience, that is not the case. We understand the molecular makeup at the DNA level of your cancer and how it changes over time. So this is another important concept. I told you, target therapy works on a specific target for a while, but not forever. And that's why target therapy doesn't cure cancer, only improves and controls the cancer for a period of time, months or even years. Why they stop working? The reason is because of a resistant molecular event. So let me tell you, cancer develops in the first place because the normal tissue at the DNA level develops mutations. The mutations of the DNA develop under the pressure of the environment, under the pressure of some medications, under the pressure of radiation, environmental radiation, etc., etc. Now, we characterize that mutation. We use it as a target. We put the patient on target therapy. The cells are smart. They develop another mutation, and those are called by us resistant mutations. So they are used to resist the target therapy. That's the way the cancer cell escape the control of the target therapy. How do we approach that situation? Well, if we have another target agent for the new mutation, the resistant mutation, we can use it. So these days, this so-called precision oncology is like a sequence. It's like reading a book. A book has many chapters. You can read the first chapter, and when you finish, you find that the tumor, unfortunately, under the pressure of the first target agent, started growing. So we do the molecular testing again. You identify the resistant mutation. You have now in the backup, in the back burner, a new target agent for that specific resistant mutation. That happens these days for breast cancer. It happens actually for some colon cancers. It happens for lung cancer, which has become, in the last 15 years, a model, a molecular model for the management of some type of lung cancer. So, to make predictions about the risk of developing cancer. So, molecular testing also can do this, but it's different. This is not predicting response to a specific treatment. This is actually analyzing not patients, but individuals, you and me, that supposedly don't have cancer. We can analyze our genes, the genes we were born with, and we can find if there is any aberration that we don't know how we took from most likely our parents. We were born with them. And they actually predict the risk or the predisposition to develop cancer in the future. That is very well known for breast cancer, also for cancer of the ovary and some other cancers, and more recently even for lung cancer. So that is part of genetic counseling, and that is a totally different field to the one that we have been talking until now. So these are examples of molecular markers that we have some targeted agents. For breast cancer, we already talked about ER or estrogen receptors. We talk about tamoxifen, and over the past 40 years, they have developed different types, similar or different to tamoxifen, to block the estrogen receptors or the production of the hormone estrogen in the body. HER2, BRCA1 and 2, etc. are other markers. BRCA1 and 2 can play actually different roles. BRCA is part of the genetic testing, has been for many years. And if you do carry BRCA1 or BRCA2 mutations, even when you don't have breast cancer or ovarian cancer, and even prostate cancer, then you can predict that you have some risk to develop those conditions. And because of that, the oncologist or the primary care physician can adjust the screening for those cancers through your life. In lung cancer, EGFR, ALK, ROS, RET, BRAF, MET, etc., they are used as targets for targeted therapy. PD-L1 is a different animal. PD-L1 is a protein expressed on the cells of some lung cancer cells, and it can be used to determine patients that may respond to a new form of target therapy known as immunotherapy. Colorectal really lags behind breast and lung. So there are some targets, but unfortunately, it has been very difficult to target these targets. And because of that, we are not as successful with target therapy in colorectal as we are these days for breast and lung. Gastrointestinal stromal tumors, also called GIST, is a type of sarcoma. We know those patients actually have mutations in a gene called KIT or PDGF, receptor A. Those mutations are used these days daily to target the mutation and to treat those patients. Leukemia, there is more there, ovarian, again, BRCA1 and BRCA2, like in breast cancer. Even in brain tumors, these days, we know there are some targets that can be used to fine-tune all treatments or to use target therapy to treat these patients. IDH1 and 2, MGMT are only a few examples. Like for instance, if you go back up there to lung cancer, EGFR now is recognized as a target for some patients with brain tumors. So again, the concept I gave you before. You can see in the same clinic patients with breast and ovarian cancer because they have the same mutation and they are going to be treated with the same target therapy, even when they are totally different cancers. So the same lung and brain tumors can be seen in the same clinic now because you can target EGFR in both of them with the same treatment. So down there, any solid tumor, MSI-high, NTRK, NTRK, they are newer targets, and we'll talk a little bit more in a few slides. Now, there are a few questions that you may ask your cancer doctor or your primary care physician. Does my type of cancer have biomarker tests? If yes, can I get tested? So why? Because there are some cancers, look at the chart that I showed you before, that unfortunately they don't have any targets, or they may have targets, but we may not have the target agents. So some cancers we do molecular testing, for some others these days we don't. What biomarkers will you test for? That is a good question because we don't test as we used to do 10 years, even 5 years ago, one marker, one mutation, and then if it is negative, another, and if it's negative, maybe another one. We do a panel of mutations. These days, we may check 40, 50, 75 different mutations or some kind of amplification or fusions. So in one report, in a week or 2 weeks, we can have the comprehensive information about the molecular makeup of the tumor. So you may have more than one target agent, and then you decide which one may be the best for that specific patient's tumor or cancer. So if your cancer has a specific biomarker, your doctor may decide to use a therapy called target therapy to treat your cancer. That is a concept that we have been talking about, and I gave you some examples. So target therapies are treatments that block what causes the cancer to grow and spread. These targets some of the difference between cancer cells and normal cells and can work in several ways. We talk about that also. So this treatment targets some of the differences between cancer cells, molecular differences that we call targets, and we have been defining them with examples in the few last slides. Now, for some target therapy, biomarker testing is required prior to use. I would probably modify this statement, not for some, but at all target therapies. You have to identify the target before you use the target agent. If the target is not there, the target therapy will be a waste. It's not going to work. Very few times target therapy, and we don't know how, may work in patients without the target. Maybe because the tests we have done looking for the target miss the target, but maybe the target or something, some molecular aberration similar to the target may be there, allowing the target therapy to work. But again, one more time, we usually wait to characterize or find the target before we start using target therapy. There is no guarantee that target therapy is going to work, even if you have the target there. Why? Because the one we think that is the target may be one of the targets. This may be one of those small cells that may have more than one mutation that is used for the cancer to grow and multiply and metastasize. And if that is the case, unfortunately, you inhibit or block one target, but the other ones continue pushing the cell to grow and metastasize. So target therapies work by tagging cancer cells. That can be done actually from the outside receptors expressed on the surface of the cancer cells, or the inside molecular pathways well recognized and characterized in the inside of the cell, destroying the cancer cells directly or cutting off the blood supply to the tumor. This is a very interesting concept, and this concept actually we have been entertaining and even using to treat patients different types of cancers, lung, colon cancer, to some extent breast cancer, etc., for many years. So we know actually now that there are growth factors, they are like hormones in our body that are produced to make normal cells grow. Between those cells, some cells in the arteries and the veins, the vessels. Those vessels are needed in the body for the normal metabolic functions that keep us alive. But that circulation is also important, very important for the tumor to be fed and continue growing and developing and metastasizing. We also identify that there are some receptors inside the normal circulation cells, the cells of normal vessels, arteries, and the cells of the abnormal artery cells. There is a molecular difference between the two. And growth factors grow different inside an artery of a normal organ and the artery of a tumor. Because we identified that difference, we took advantage of that difference, and we developed monoclonal antibodies against growth factor that makes those artery cells grow. And by doing that, we can cut the blood supply or the circulation inside the tumor, but not the circulation in the normal tissue. And by doing that, we can use these anti-angiogenic agents, targeted agents, to cut the circulation of the tumor, not as a single agent, but in combination with chemotherapy or even some other target agents. We can cut the hormone supply to the tumor. We already talked about breast cancer, and we talk about estrogen. Very similar is for other tumors, like for instance, cancer of the ovary, and even more, cancer of the prostate, with androgen carrying the supply of this growth factor. That's what androgens are for prostate cancer, that fuel the growth of those cancers. And finally, target therapy can work by taking the brakes of the immune system. This is what we call these days immunotherapy, another type of target therapy. So what happened? This is what happened. You have the cancer cell that, one more time, is very smart. The cancer cell can communicate with the normal cells in your immune system and can tell those immune cells, don't attack me, don't kill me, stay resting, go to sleep. And the immune cell obeys. The immune cell doesn't attack the cancer cells, and it goes to sleep. So we identify that communication between normal immune cells and the tumor cells. These monoclonal antibodies go and bind those molecules that promote the dialogue, the discussion, or the conversation between the cancer cell and the immune system. As soon as the cancer cell cannot take the normal immune cell, step away, don't attack me, the immune system is activated, start attacking the cancer cells and kill them. That is the whole principle of immune therapy, and that is how these monoclonal antibodies called immunotherapy, taking on the brakes of the immune system. Now, the immune system cells are full speed going, finding, attacking, and killing the cancer cells. So this is something, attack cancer cells, that we talk about. Destroy the cancer cells is a concept that we already talked about. Cutting off the circulation or blood supply, we talk about that, and we can answer some questions during the question and answer session if you have any specific one. Tumor supply, again, hormones are the fuel of some cancers like breast and prostate cancer. And then taking the brakes on the immune system, sometimes cancer cells uses these checkpoints to disguise themselves as your normal cells and keep the immune system from attacking them. This is another way to express the concept that I gave you an example just a few minutes ago. What are the names of the target therapy or drugs that I could or will receive if I have a target? Well, there are so many these days, and it depends not only of the type of cancer and the type of mutation, but the timing of the the course of the cancer, because it's a totally different approach to target therapy if your cancer has been just diagnosed and the target has been just found, than if you have been exposed to some target therapy, you have been on target therapy and your cancer was diagnosed 2, 3, 4 years ago, and now we are looking for other targets, and now we need to use different other target therapy, alone or in combination. Where and how will I receive my treatment? Is there anything I should know about handling the drug? Well, this is so specific to each target agent. But in general, question like, should I wear gloves? In general, no, that is not the case. You handle the pills the same way you handle an aspirin, a pain pill, or any other. Taking pills at any time, well, at the same time, not exactly. There is some flexibility, but about the same time. This is not an antibiotic. And every day, well, it depends. Some target agents have to be taken every day. Some target agents, however, are taken in cycles, like 20 out of 28 days, 15 out of 21 days, etc. Even some target agents these days, we know can be taken once a week or even less. So how often will I get the treatment? Well, we answer that every day or maybe 21 out of 28 days. For how long? Depends. First of all, we check. And as long as you are deriving benefit, because the cancer continue shrinking on CT scan or PET scan, you continue on the treatment. If the cancer starts growing, maybe time to stop the treatment and go on a different treatment. So for how long, it all depends on the benefit you are deriving. So what side effects should I expect and how will we manage them? So again, one more time, it depends on the target agent, but most often actually those may give you some fatigue, some skin rash, it may give you some diarrhea, but again, they are different one from the other. Will I receive target therapy alone or in combination with other treatments? In general, these days, most target therapies are given as a single agent. Just now, for the last, I would say, few years, and even actually since June, that we learned actually from our national meeting, there are some combinations of target therapy or target therapy with chemotherapy, etc., that we have been doing again for a few months or for a few years. How long will I need to receive this treatment? We answer that. Immunotherapy, for instance, if your tumor doesn't progress, the standard is 2 years. It looks and feels like a long time. You receive the treatment every 3 months, every 3 weeks, every 4, or even every 6 weeks. But again, in between, you don't have to come in the office. We don't have to check for any side effects on the blood count. But again, you may have some side effects and you may have to come in the office to take care of them. These are examples of targeted agents. EGFR, we said actually is a mutation most common in lung cancer, and there are first generation erlotinib, second generation afatinib, and there is one that is missing there that is called osimertinib. It's also actually called Tagrisso, and it's a third generation of EGFR target agent, and those have been used since 2004 to treat patients with lung cancer, mainly advanced disease, but more recently, even early stage lung cancer. ALK is not a mutation, it's a fusion, and you have, again, crizotinib, that is a first generation, alectinib, ceritinib, second generation, brigatinib, third generation, and more recently, lorlatinib, that is a fourth generation of ALK inhibitors. That is a mutation very common in lymphomas, but the agents that I mentioned before are used because of the same alteration called fusion with different partners present in lung cancer. BRAF can be present in melanoma, colon cancer, also actually in lung cancer, etc. In this case, the two target agents that you see on the screen, dabrafenib and tremetinib, are used in combination. PR, that is for breast cancer, these are hormone therapies. Tamoxifen, that we mentioned before, is the one that blocks the receptor, and aromatase inhibitors like arimidex, arimidex, etc., and those actually block the production of the hormone. And then other agents like you see on the screen. HER2, that is actually mainly for breast cancer. That was a breakthrough several years ago in the 90s with breast cancer, But more recently, we identify that the same aberration in the form of mutation or amplification can work in lung cancer, in patients with cancer of the ovary, even in head and neck cancer, etc., in colon cancer, and we can use some of these monoclonal antibodies to treat those patients. Others on the screen are just examples. And again, if you have any specific question, I will be very glad to entertain them. Now, there are two target drugs has been approved more or less recently for any solid tumor. This is not for blood cancers like leukemia, lymphomas, or myelomas. As long as the tumor is positive for what we call MSI high. This means that you are born with some defects in the enzymes that repair your normal DNA. So your DNA now is normal, but your body doesn't have the enzymes, which are the tools to repair the DNA if there is any injury to the DNA by some kind of attack from the environment. So taking advantage of that, there is an immune agent called pembrolizumab that is a monoclonal antibody anti-PD-1. The brand name is Keytruda, that can be used for those patients. Even patients with salivary gland tumors that we don't have any treatment for, this agent is very effective as long as you find this MSI high. In tumors that test positive for NTRK, there is a gene fusion that has been recognized a long time ago, but very recently we found actually a target agent just very recently in the past year and a half called larotrectinib and another called neotrectinib, and the two of them actually block NTRK gene fusions and can treat those patients. One more time, that can happen for rare tumors or more common tumors. The incidence of this NTRK gene fusion is very low, and the same for MSI high. In general, less than 3%. NTRK gene fusion, however, is pretty common in some tumors like GYN cancers, endometrial, uterus, ovarian cancers. Common side effects from target therapy, we mentioned them: skin rash, dry skin, itching, fatigue, and a flu-like reaction, but may vary according to the target agent. Sometimes target agents may use in combination with chemotherapy, radiation, immunotherapy, or hormone therapy. So far, however, these combinations are not very common, mainly actually for target therapy like the pills that I mentioned before. Most of target agents are pills, and they are not so far combined with any other agents in general. Example of HER2 in breast cancer and some other cancers: 20% of patients with breast cancer carry this HER2. This is an amplification of the gene. There are specific target drugs against HER2, and these treatments actually essentially change breast cancer tumors with poor prognosis into breast cancers with much better prognosis. So HER2 mutations or amplifications, when you diagnose a breast cancer patient 20 years ago, 25 years ago, was a very poor prognosis, we didn't know how to treat those patients, and unfortunately, we lost those patients in a matter of months or few years. These days, by the introduction of these monoclonal antibodies or even pills, we can convert these poor prognosis breast cancer patients in much better prognosis. The benefit for some, but not all, was already introduced. Not all subtypes have a target therapy. Of course, let me give you the example of lung cancer. Only about 40 to 45% of lung cancer patients, they carry a target that we can treat with target agent. The other 50, 55%, we have not identified targets, or if we identify them, we are still short to having target agents that are successful in those cases. So even if the tumor has a biomarker that matches a target therapy, it doesn't guarantee that the therapy will work for you. There is nothing in oncology like 100% response rate. Unfortunately, even if you have the right key for the lock in the door, sometimes for whatever reason the key doesn't work and you cannot open the door. Here is the same. You believe you have the right target therapy because the target is there, but you don't know why the target therapy doesn't work. However, target therapy, if the target is present, works in 55 to 85% of the cases, which is much better than any other treatment that we had before the introduction of target therapy. Target therapy is not a cure. We already talked about that. So the cost of molecular testing is very high. It's in the thousands of dollars, but it's coming down and down. And also insurances that before refused to cover the cost, now, because of the benefit that we have shown to derive from this biomarker testing and the target identification, more and more cover the cost. Some clinical trials also actually cover the cost of molecular testing, but in general, only if we are looking for experimental targets and experimental target agents, not for standard targets or standard target agents. Some patient advocacy groups can help you find biomarker testings if you need. You can contact a patient advocacy group that specializes in your type of cancer. Many target therapies are very complex drugs, can be very expensive. It's too expensive so far, and the cost, unfortunately, is not coming down. However, insurance companies are covering more and more. There are also many ways, like even you can get information in the cancer support community.org/cost website, and you can actually see for copay assistance to cover actually out-of-pocket costs, etc. So again, even if they tell you that it's very expensive, don't stay there, don't sell your house. And yes, I have seen that done by patients of mine to cover the cost. The insurance company, the pharmas, everybody actually can help you. It's just a matter of finding the right information. Now, changing the page to genetic testing for inherited cancer risk. This is totally different. This is part of genetic counseling. These are not patients. These are normal individuals like you and me that we believe don't have cancer right now in our body. So it's testing your normal genome, your normal genes. And by testing them by a similar technical approach to checking for the mutations that we mentioned before, you can find some mutations. You can find some aberrations in the DNA. Now, you came with those aberrations to this world. You may have inherited them from your parents, or maybe product of some kind of genetic injury during the process of, when you were conceived. In any case, this actually can, can tell the physician if you have any DNA aberration that may give you risk or predisposition for the development of cancer. Some of them, like BRCA1 and BRCA2, for instance, can be used in both ways, can actually give you the risk to develop cancers like breast, ovarian, etc. But also, if you have those mutations and you develop the cancer, can also be used as a target to use a specific target agents. So genetic testing finally can show if you are more likely to get cancer at some point in your life, if you have actually specific inherited changes in your genes that can help your doctor to design some kind of a screening program for you for specific cancers like colon, breast cancer, etc., ovarian cancer, between others. And finally, if unfortunately you develop the cancer, there is again the BRCA example. There are drugs called PARP inhibitors, take advantage of that mutation and can be used for treatment. So there is the BRCA testing. And let me tell you one thing. Some of you listening to this workshop may be breast cancer patients. You may have undergone genetic counseling in the past, and you may have tested negative for BRCA. Now, if that testing was done more than 5 years ago, you need to be retested. The testing 5 years, 15 years ago was totally different than genetic testing for breast cancer, and even for the finding of BRCA type of aberrations that are available today. So one more time, if you are a BRCA negative breast cancer patient and you have not been retested in the last 5 years, you need to communicate actually or call your genetic counselor or your oncologist or whoever and be tested again. So cancer support community, the American Association for Cancer Research, and you can look on those websites, the American Cancer Society, the National Cancer Institute, through the cancer.gov, etc. You can look actually for different treatments, specifically for precision medicine, for standard of care treatments, or for research. So the Cancer Support Community Atlanta offers free virtual support services for those affected by cancer. So stress reduction and gentle exercise classes, nutrition seminars, education programs, support groups, they are available through Cancer Support Community Atlanta on Facebook. I think that I'm going to leave it there. I give it back to Katie. Thank you.
Great. Thank you, Dr. Bordoni. I encourage anyone interested in finding out more about the clinical trials available to visit Georgia Cancer Specialist's website or to connect with Northside Hospital Cancer Institute at the contacts listed below. And for information on available screenings, please visit Northside Hospital Cancer Institute's website. And before jumping into the Q&A, I'd like to share a couple cancer support community resources, the first being the Cancer Experience Registry. The Cancer Experience Registry is an online community that allows people facing cancer to share their experience. You can access resources and connect with one another. It's free, confidential, and open to anyone who has been diagnosed with cancer or providing care to a cancer patient. The next is My Lifeline, which allows you to create your own private website where you can keep family members and friends updated, all while connecting to a network of support through various online discussion boards. All right, so we're going to go ahead and jump to the Q&A where everyone's welcome to enter their questions into the program chat box. The first question I'm going to jump to is, at what point after being diagnosed should I receive biomarker testing?
That is a very good question, and the answer these days is at different points. In the past, actually, we thought that it was a one-time, we learn from the cancer, makeup, molecular makeup, and that was it. But we know now it's different. And I referred to that to some extent during the presentation. The first time is when you are diagnosed. However, there is no point identifying some targets at the very beginning when you are diagnosed with cancer if your cancer is a very early stage, because target therapy these days is mainly used for advanced cancer. So if we identify a target, we wouldn't know how to use the target agent, even if you have the target, if the cancer is very early stage and can be treated with surgery, radiation therapy, or some other standard approach. Now, if you have the target and you have advanced cancer, the target can or may not be used with target therapy available for first-line treatment of your cancer. As I told you before, under the pressure of the treatment, target therapy or not, cancer changes over time the molecular makeup through the development of what we call resistant mutations. And then periodically, you have to retest or molecular retest the cancer. And these days, you don't have to have another tissue biopsy. You can have what we call now liquid biopsy, which is take a blood sample, about 10 cc's. We can look for DNA aberration shed from the tumor into the circulation, and we can learn about those DNA aberrations, so-called targets that guide us into a new treatment specific for your condition.
Okay, thank you. And I think you might have just answered this second question, but I'll ask to reiterate it. If other treatments have failed, is it too late to explore precision medicine?
No, that is a very good question. Some target agents are approved by the FDA only for second line or beyond, meaning actually if you fail first line therapy, that could be chemotherapy alone or in combination with other agents. So the answer is no. Even if you fail prior therapies, it's still a good time to check for molecular targets. So my strong recommendation is, and the oncologists these days are very up to date because they follow the multiple ways of education, professional education on cancer. So they will know if looking for the target applies to first-line therapy. But if it's not, again, one more time, yes, you fail first line, and the cancer doctor, the medical oncologist, should look for a target through molecular testing to maybe use target therapy as second line or beyond.
Okay, great, thank you. And I think earlier in the presentation you talked about this, and it sounds like maybe this list is growing, but can you discuss which cancer diagnoses respond best to precision medicine?
Many these days. So I think that the question is, or the difference is the percentage of different cancers that responds to target therapy. For instance, breast cancer is an example and has been for decades of a type of cancer that we early on identified many targets. We developed target therapies like the tamoxifen, like the Herceptin, and more recently PI3K inhibitors, etc. And they respond very well and for very long to those target agents. Lung cancer more recently became an ideal model for molecular testing and molecular treatment. And again, the treatment actually works not as long as in the case of breast cancer, but for pretty long time. Alternating different target agents, you can actually obtain responses and control of the disease for several years. Other diseases like, for instance, colon cancer, you know the target is there, but target agents don't work as well. And even if they work, they do for a short period of time. So again, one more time, I would say, first, breast cancer has more targets, better targets, we know the biology better, and the targets work for longer. Then maybe lung cancer, less or maybe as many target agents, as many targets, but again, the response not as good, at least until now. And then other tumors like colon cancer, GYN cancer, etc. In GYN cancer, for instance, just now, target agents are being defined for GYN oncology, also for prostate cancer. So that is my best way to answer your question.
Okay, and it sounds like there's a growing knowledge and understanding of targeted therapies in the world of oncology. Do you know if biomarker testing and precision medicine have been used to treat any other diseases?
Interesting question, and the answer is yes. There is a specialty, there is a field in medicine, rheumatology, that is very interesting. Also, infectious disease. Interestingly, actually, cancer is not much different in many aspects to several infectious diseases. For instance, HIV. HIV actually with the, HIV virus, etc., that was recognized and isolated in the 70s, in the 80s, and we developed anti-HIV treatments, etc. We, the medical oncologists, learned a lot from HIV about immunotherapy, about targets, how to modulate the, the cell infected as an analogy of cancer cells. So target agents have been used in infectious disease. In rheumatology, it's being used every day. Even some of the same monoclonal antibodies that we used to treat successfully different types of cancers are used in rheumatology. Rheumatology is becoming one of the most expensive fields in medicine. And the reason is because of the broad application of these new, very expensive monoclonal antibodies in treating patients, for instance, with rheumatoid arthritis, lupus, etc. So the answer is yes. There is a kind of cross, beyond boundaries between different specialty to understand and to learn from each other.
Yeah, that's very interesting. Thank you for sharing that. I'm going to jump to some questions that participants have entered into the chat box. Is there any targeted therapy for the ATM gene mutation?
So ATM, we these days actually put it together with BRCA. So PARP inhibitors that I mentioned before as a target agent for patients, BRCA1 or 2 positive, regardless if the patient is a breast cancer, is an ovarian cancer, or is a prostate cancer patient, is very similar to ATM. ATM actually is another mutation that is based on the same defect of the DNA or aberration of the DNA. It's also actually is the lack of enzymes to repair the DNA. So BRCA and ATM patients, they have a similar aberration in the enzymes that repair the DNA, and they can be treated with a target agent. These days, there are several PARP inhibitors in the market, and all of them actually can be treated for induction or for maintenance of treatment for those conditions. We have a clinical trial open for all patients with ATM or BRCA, and we found patients treated with a new experimental PARP inhibitor, and those patients actually, we found the ATM mutation and the BRCA in patients with sarcoma, pancreas cancer, of course, breast cancer, etc. So many cancers, they have the mutation, and as long as the mutation is there, we treated those patients with a combination of the PARP inhibitor and immunotherapy, or just the PARP inhibitor.
Can you explain the difference between a mutation versus an amplification? If you have EGFR amplification, is it treated any different than EGFR mutations?
Great question. So let's say actually today is August 2004, and we were actually debating that right question. We have discovered already the amplification, which is an extra copy number, can be 1, 2, 3, 4 copy number of a normal gene. So that is amplification. At the same time, actually, we just then have isolated in 2 different labs, the 2 of them actually at Harvard University. At the same time, they identified an EGFR mutation. And there were mutations in very specific locations within exon 19 and 21. So for EGFR amplification, we use that to use target therapy just developed in patients with lung cancer. What we found is that many of those patients with the amplification didn't respond. However, there was a seminal paper in the New England Journal of Medicine published in 2004 talking about the aforementioned mutation in exon 19 and 21 using a specific tyrosine kinase inhibitor, an inhibitor of those mutations on a specific pathway and the cell. And out of, I think that it was 10 patients, 8 responded. And the response was very deep, clinically very meaningful. That is the difference between amplification and mutation. At least in lung cancer, the amplification, copy number of the normal gene, is not enough for target therapy to work. However, if you carry the mutation, and the mutation is what we call an actionable or classical mutation, target therapy works, and it works very well. So they are not the same. They are very difficult in terms of the meaning from the therapeutic standpoint. For HER2 in breast cancer is different. HER2 amplification can be used as a target for treatment in breast cancer with HER2 positive cells. In lung cancer, there is now a recognized condition with HER2. Can be amplification, but mutation is the main one that respond to HER2 target agents, monoclonal antibodies. So even the same target, if it is amplification or mutation, it works different in different conditions. So the answer is no. Applied to lung cancer EGFR, amplification doesn't mean much. Mutation, it means a whole world.
Okay, and you mentioned lung cancer a second ago. I guess earlier in the presentation, you mentioned that 40 to 45% of lung cancers have identified biomarkers. Do you know, are they adding more biomarkers? Are they continuing to be identified?
Sure. So some of the biomarkers on the chart are relatively new. We treat patients with those, like for instance, BRAF mutation, or patients with a HER2 mutation that I just mentioned from very recently. Even actually the treatment for HER2 mutation in lung cancer, I believe is not even FDA approved. So those are very, very recent targets identified in lung cancer. But probably actually some like MET amplification, MET exon 14 mutation, those are even more recently identified. And there are some actually that are identified as we speak, and some of them that still the mutation, the fusion, etc., is very experimental. So the answer is yes, and TRAC is another one that we use in lung cancer since I would say that actually a year and a half or so. So yes, they are all very recently incorporated as targets in lung cancer.
I think our last question before we wrap up is, how has COVID-19 affected clinical trials?
So that is a very interesting question. And the way I answer that question, I think that is going to be totally different if you ask me the question in 2, 5, or 7 years. Like in the example I presented before with HIV, we couldn't conclude some of the changes. I mean, we saw them, we described them, but we didn't know how to put them in perspective. So just a few years ago, we answered those questions that were formulated in the era of HIV discovery. The same with COVID-19. The only thing that I can tell you is that we track in our practice the number of patients infected with the virus. And even when at the beginning we thought that patients with cancer maybe were more prone to be infected with the virus, we are seeing that probably that is not the case. Even there are some publications from different parts of the world, at the beginning from Asia, that, taught us, what, patients with cancer, mainly patients with, for instance, lung cancer, they get infected more often, they die more often, they go to the ICU or more often than other type of cancers and than normal patients. And then we learn, well, it may not be because of the cancer. It may be because they have more underlying conditions, like diabetes, like hypertension, etc., COPD, between others. So we are learning. I don't have to tell you actually how many patients, unfortunately, we didn't put on clinical trials because of the pandemic. And the reason was because patients were, in shock and very, very concerned about coming in the office and of course acquiring the infection because of the contact with the staff or other patients. So in that regard, we have lost many patients from being accrued and benefit for clinical trials. Interestingly, if there is patients that were affected more by the pandemic, maybe actually were patients on immuno and maybe to some extent on chemotherapy, but there is no data, or the data seems to be negative for the impact of target therapy on COVID-positive cancer patients. So again, this is just a learning process, and the answer I'm giving you now that is not very clear-cut is because we don't know.
Okay, thank you. And you're getting a lot of thanks in the program chat box. So thank you, Dr. Bordoni. As we wrap up today's presentation, do you have any final thoughts you'd like to share?
The only thought that I have actually is to congratulate you for putting together this kind of forum for ordinary people, for patients, to be informed what, this kind of new field in the treatment of patients in general and cancer patients in particular, to try to understand, because knowledge is what is going to help advance the field and advance the treatment of cancer patients in general. So thank you for the opportunity to, to be part of this program, and thank you to all the audience.
Well, thank you, Dr. Bordoni, and thank you everyone for coming. We definitely couldn't put these on and put these together without the support of the healthcare community. So we're so grateful for you sharing your time and expertise with today's program. Thank you everyone for coming. Again, if you could please complete the evaluation form using the link entered in the program chat box. And if you're interested in more information on cancer support community, please visit us at cscatlanta.org. All right, thank you, Dr. Bordoni, and thank you everyone for coming. Take care.
Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.